So thank you very much for attending this session. So the first speaker is Christophe Rodriguez. So Christophe is professor in virology at the University of Paris-Est Créteil, and he works in the Department of Microbiology in the French National Reference Center of Hepatitis B, C, and Delta. And he's also heading the next generation sequencing platform at the Henri Mondor Hospital in Jean-Michel Pavlovsky lab. So Christophe, the floor is yours.
So thank you for this introduction. Thank you also for this invitation to speak about this topic, emerging data on hepatitis E. So I'm not specialist of hepatitis E, more specialist on emerging infectious disease. And we have now a new hepatitis E we have detected and which have also been detected by other teams in Europe. So I think it's really important to speak about that because the diagnostic is not so easy to do. So just coming back on that, first, because I really want we speak about the same thing. We have recent changes in hepatitis E taxonomy, so it's important to speak about the same thing. So you know probably very well the human HIV, which is classified in Rocahepevirus A in previously and now in Pathophysiology balayeni. But I would like more to speak about Rocahepevirus C, which is named now Rocahepevirus ratti, which have been described as in human infections a few years before and now in Europe. So, as you know, maybe there's Rocahepevirus ratti have been described in human infections in 2018 in India, and it comes from it has been described in animals at first time in 2010 in rodents and particularly in rats, and it has been detected at this time but by a particular qPCR which have been developed specially for this virus because it's not detected by conventional qPCR of HIV, which is used in diagnostic for human HIV. And the first description in human hepatitis was done in 2018. It was in India, and it was described for the first time in a patient. So the question was, at this time, do we have this virus in Europe? And several studies have been done in Europe by in different countries. I show there's two ones. One in France, which have been done during from 2019 to 2020, mostly in immunocompromised patients, and another one in Germany on very different patients, not only immunocompromised patients, on a more longer period. And for those two studies, no patients were reported to be infected by this type of viruses, with a dedicated qPCR which was designed especially for this virus. But nevertheless, we know that this virus is present in our countries in rats, because there is several studies that have been done in animals that show that we have this in India, sure, because it has been described in this country first, but also in China, USA, but also in our countries in Europe by, again, qPCR dedicated to that. And finally, we had our first, the first study which have been published in Europe, which reports the presence of the virus in patients, was done finally the summer last year. So it's a study where the Spanish team tested two types of cohorts. One which have been tested because the patient have an hepatitis of unknown origin, and another one for which we have an acute hepatitis with only IgM HIV which are positive. And from these two cohorts, 3 patients were detected positive and were described for the first time in Europe. Now, just coming back on what we do in my lab. My lab is dedicated to find microorganisms which are in general not detected by conventional approaches. So we are working on complex infectious disease. And for that, we have developed 5 years before a shotgun metagenomic technology, which is a very easy concept, finally, when we think about it, because it just sequences the entire content, the DNA and RNA content of the sample. But in practical, difficult to do because the technical process is not so easy, and the analysis is very difficult. So how it works in practice, so when you have an infection and you collected a sample, the sample will contain microorganisms and human. So you will have first to do an extraction. This extraction have to be very particular because you don't know what you will find. You have to be confident in fungi, parasites, bacteria, viruses, and it's very difficult to do it in the same time, in the same extraction, because the external structure are very different in the different microorganisms. So that's so we developed a specific one, which is today okay with that. And after that, we prepare the DNA and RNA for sequencing by an approach which is based on a random fermentation. Which has the capacity to avoid finally the PCR, which is really important because when you have a PCR approach, that means you need to choose some primers, so you have to choose your target you will assess. By this approach, which is a random fermentation, you will not have to use primers, and because of that, you can finally sequence the entire content of your sample and finally ask the question after. So when you obtain your sequence by next generation sequencing, you will after compare the sequence to a very big database which is dedicated to that in our lab. So we developed a special software for that. And the sequence will be annotated with the reference name, which is the closest of the database comparing to the sequence we obtain. And finally, it works for everything, including the virus we don't know, for example, because even when there is nothing in the database which match with the sequence you obtain, the software has the capacity to say you what is the closest sequence comparing to the one you have. So even if it's something new, you can maybe have the family or something like that, and you know it's new, but it's including in something you know. So after, we have other software which have the capacity to rebuild the genome and finally describe the new one. So we use these techniques for a long time now because this year is the 5th year for which we do this activity in clinical diagnostic. We are accredited for that. We have tested more than 10,000 patients for the moment, so I think we have a big experience for the moment. And it's used by infectious disease clinician, internal medicine, etc., for patients for which we already have a conventional diagnostic and for which we have nothing. By this way, we discover a lot of viruses or viruses which have been discovered in very particular clinical presentation, for example, and we discover approximately 1 new microorganisms each year. So it's approximately what we have. For the rest of the activity, it's something very rare or something which is known, but not with this clinical presentation, for example. So coming back on HIV, during this activity we have patients for which we have samples which are sent to our lab because of hepatitis of unknown origin. And last year we have one of them which have a renal transplantation. It's in general immunocompromised patients we have in our activity. Which were a kidney transplantation and which had an HBV infection in the past. But HBV was okay, treated with success. and so with a negative, undetectable viral load. After that, many years after, this patient had a trip in India and come back with an transaminase elevation. He was tested for all viruses of hepatitis, and all was negative except the IgM of HIV. But because the viral load of HIV was negative, it was concluded that it was probably a false positive. So finally, they didn't know what the patient had, and finally the patient evolved to cirrhosis and had a double kidney liver transplantation. But immediately after, the patient has again abnormalities, liver test abnormalities, and finally they didn't understand what has the patient. So finally, last year, they decided to re-explore the patient from the beginning and send us a metagenomic for blood testing. So this is the story of the patient. And we had the test of metagenomic at the very end of the history. And during this long history, we had a lot of tests, we can see, for HIV, which were each time negative for viral load and positive for serology. But if we follow the recommendation, we'll see that after we have maybe to conclude that it's a false positive, so we will have to change that probably. So metagenomics gives the results. This result, it was a Rocahepevirus. So because we have a lot of sequence for this virus which have been produced by metagenomics, we have also the capacity to rebuild the genome. So we have the capacity to do a phylogeny and finally conclude that yes, it's a Rocahepevirus ratti, and this patient have this infection. So we decided to explore the history of the patient, and the only things we have for this patient was an FFPE liver biopsy that was provided by pathology in our lab. So because the metagenomic works on FFPE biopsies, and we found the viruses just immediately after the transplantation. So probably the patient was already positive before the transplantation, reinfect himself with its own HIV, and probably because when we see the abnormalities of the patient, probably this patient has been infected during its trip in India. We don't have the proof of that, but it's probably that. So to conclude on this patient, this patient were always undetectable by qPCR approach using a commercial approach. And the recommendation, when we follow this recommendation, it's in favor of a false negative of IgM HIV, so that's why the clinician don't think about this new virus. So finally, there is no possibility to diagnose this virus by conventional approaches. And it's sad because this patient finally had a ribavirin treatment, and it was good for the patient, so we have a treatment for this patient. And now this patient is undetectable, so it's good for the patient. 3 months after this first case, we had another one. I will be short on this case because it is exactly the same finally. The two patients are very different. They are not living in the same place. They don't know together, but it's very different patient. But it's the same history. Again, a kidney transplantation, so immunocompromised patient. Again, a history of transaminase elevation. And again, all was negative for hepatitis exploration, excepting IgM for HIV. But this time with a ratio which is less important. Yes, it's positive, 4 is positive, but it's not 15, for example, so it's less important. We will come back on that also. And the patient evolves in a decompensated cirrhosis, finally, very quickly, in approximately 1 year. So because of that, the patient was treated by ribavirin we don't have the diagnostic at this time, but they test the ribavirin because they don't have any things to do. But the patient had a severe anemia, so they stopped immediately. So finally, the patient was not treated by this treatment. Again, 2 years after, and because the patient was very severe, they decided to re-explore the patient from the beginning, and they sent us again a sample to test this patient, and we find again this new virus, Rocahepevirus ratti, and what is an issue for this patient is we cannot use ribavirin due to side effects, so this patient is waiting for a new transplantation. Finally, if I'm coming back on the literature, there is a new publication which reports finally the biggest cohort of patients which are positive to this virus. This was an Indian cohort, and what we have to know is finally this infection could touch very different patients, which are immunocompromised or not, which could be acute or chronic. And finally, which is also important, in systematic testing, we can see that some patients have no IgM. So for the one we had until now, IgM was positive, but they also discover patients with IgM which are negative. So it's not also a good approach. The problem with the guidelines today is when we test the patients following the EASL guidelines, we have this paragraph which says that finally the specificity of IgM assay is not optimal, and it's not sufficient. It's not a sufficient robust marker for diagnosis. So because of that, a lot of clinicians think that because we have just isolated IgM for HIV, finally it's just a false positive, and they try another disease, but not this one. So in the paper which have been published by the Spanish team the last summer, they say that first it's important to have in our minds that some individuals have no IgM. And they say that probably go through IgM, positive IgM to do the diagnostic is not the best idea we can have. We have to rebuild the entire recommendation today for this virus, which is present. So, to finish, Rocahepevirus ratti is a new virus in Europe, which circulates in patients at least in 2 countries since at least 1 year. I don't know if we detect this new virus because we have new technologies or because it's a real emergence, I don't know. We have to do epidemiological studies for that. What is important to know is this patient could go to cirrhosis very quickly, so it's important to detect them very early in the diagnostic because they can have severe disease and because we have a treatment for this disease. But the problem is the diagnostic today is difficult to do. We have no commercial kit to do the qPCR for HIV, and HIV IgM are not always a good testing for this patient. So we absolutely need new guidelines to include this virus in testing. We have to know that the guidelines, the last one, are were produced in 2018, which was the year of the discovery of the virus for the first time in human. So that's why also the guidelines could not be good for this one. So I thank all my team, and I thank you. And if you have some question, I'm for you.